Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Behind the Knife wants you. Yes, you. We are officially looking for our next class of BTK fellows. We need creative residents heading into their research years who are ready to build the next generation of surgical education content. You'll get mentorship, access to great resources, and a global platform to display your work. Applications open in early spring with more information to follow. Dominate the day.
Hi, everyone. Welcome back to the Bariatric Surgery team on the Behind the Knife Specialty Series. We are welcomed by the incredible panel of bariatric surgeons.
Hi, this is Matt Martin, bariatric surgeon at University of Southern California.
I'm Adrian Dan, medical director of the Bariatric Care Center and program director for the Advanced GI-MIS Foregut and Bariatric Surgery Fellowship at a place called Summa Health, Northeast Ohio Medical University in Akron, Ohio.
And hey, I'm Crystal Johnson Mann. I am a bariatric surgeon at the University of Florida, where I'm also our interim medical director for bariatric metabolic surgery.
And I am Katherine Cironi. I'm one of the general surgery residents at the University of Southern California. In the last few years, it's felt like everything in obesity care has shifted. GLP-1s are everywhere. Primary care, endocrinology, social media, and increasingly they're showing up in bariatric surgery clinics.
Exactly, Katie. We're now seeing patients who are on obesity management medications before surgery, some after surgery, and sometimes both. And as surgeons, we're being asked to help navigate how these therapies actually fit together with surgery.
Yeah, I'm actually we're getting intraoperative administration of some of these medications. But that's really what this episode is all about. We're not going to be talking about surgery versus these medications strictly, but surgery with these medications in combination, how we're using them pre-op, peri-op, and post-op, and also some of the challenges that come along.
You know, there was this study that came out earlier this year that really caught my eye, and honestly, it surprised me a little bit. It was published in JAMA Surgery, and it came out of Allegheny Health. And in this study, this team compared bariatric surgery and GLP-1 therapy.
They did a large retrospective review of over 30,000 patients. About 14,000 underwent metabolic bariatric surgery, sleeve or gastric bypass, and roughly 16,000 were treated with GLP-1 receptor agonists. The team looked at outcomes and cost over the course of 2 years.
And it's the cost piece that really stood out. So over 2 years, the total cost of care was significantly higher in the GLP-1 group compared to the surgical group. And this was mostly driven by increased emergency room visits and hospitalizations.
The weight loss wasn't even close. The surgery group had an average total body weight loss of about 28%, compared to roughly 10% in the GLP-1 group.
Yeah, and I think that this really challenges some of the narrative we're hearing right now, that these medications are the cheaper and easier long-term solution. And I think clearly they're not the cheaper solution. And I think this just reinforces bariatric surgery is still the most durable treatment we have right now, while also raising some important questions about how these medications can be used with surgery rather than instead of it.
Yeah, I think surgery still reigns supreme as the best, most effective, durable therapy. And I think it's important to point out that within a clinical trial, you're going to have different results than you are in the real world. And I think that's where our good friend George Ide, a bariatric surgeon from Allegheny, showed in this excellent paper, him and his research team. But before we dive into the pre-op, the peri-op, the post-op challenges that go along with these medications, I think it's helpful to level set and quickly review the main categories of obesity management medications that we're talking about. Katie, can you walk us through some of these medications?
I'll start with the most familiar group, GLP-1 receptor agonists, like semaglutide or liraglutide. These are the Ozempics or Wegovy's we all know far too well. These work through incretin-mediated appetite suppression and delayed gastric emptying. They're injectable, have strong data behind them, and typically result in about 5 to 12% total body weight loss. They're especially attractive because of their favorable effects on glycemic control and cardiometabolic risk.
And then on the other side, we have the newer dual GIP/GLP-1 agonists like tirzepatide. So these combine two incretin pathways, the most effective medications that we have on the market. Weight loss in the 15 to 22% range in trials, They also come in weekly injectables, but from an efficacy standpoint, they really change expectations for weight loss that patients experience.
Yeah, and I think it's important, though, to remember that these are not the only agents out there. We still have the older agents that are still in use. Sympathomimetics are one classification, and this is typically phentermine. These work through hypothalamic norepinephrine release to suppress appetite. But weight loss is significantly more modest compared to the GLP-1s, usually around 3 to 7%. And these are FDA approved only for short-term use. But they are oral, they are inexpensive. There are some cardiovascular and neuropsychiatric side effects, though, that limit their use.
And finally, the combination agents. These target multiple central pathways. Bupropion and naltrexone tend to work best for reward-based or emotional eating, with average weight loss at around 5 to 9%, while phentermine and topiramate combine appetite suppression with enhanced satiety. These tend to be the most effective oral option, with weight loss closer to 8 to 12%, but at the cost of more neurologic or cognitive side effects.
And we've recently seen in the last couple of days that even semaglutide will now be available orally. It's FDA approved as of early 2026. These medications clearly work, and they're going to get better. There'll be more access to them. The routes will be more palatable to the patients, but they work differently. And they raise new questions when layered with bariatric surgery. Also, remember, bariatric surgery in and of itself increases your GLP-1s. We were GLP-1 before it was cool to be GLP-1 receptor agonists. So the real conversation begins on how do we integrate them into the practice of metabolic and bariatric surgery. I'll say one thing, those who know me, I actually in 2024 went back and got my ABOM, obesity medicine board certification, and currently I prescribe medications along with bariatric surgery to patients who aren't candidates or patients who have had bariatric surgery, and use these medications to augment what we can offer through surgical therapies.
So let's shift into the pre-op phase and talk about how some of these medications intersect with surgical decision-making. And I think this is where many of us are encountering some real-world challenges, clinical, logistical, and financial. So to start this discussion, let's start with a case.
So for this scenario, we have a 42-year-old woman with a BMI of 46, type 2 diabetes on metformin and basal insulin, hypertension, and obstructive sleep apnea, who presents for bariatric surgery evaluation. She's motivated, has completed her nutritional and psychological assessments, and qualifies for surgery. While waiting for insurance authorization, her PCP starts her on semaglutide. Over 6 months, she loses about 14% of her total body weight. Her BMI drops to 39, insulin is discontinued, and her A1C improves to 6.4.
So, and this is not an uncommon presentation. And now the question really becomes, this patient is benefiting from the medication. It has had a significant effect. But does that change her candidacy for surgery or our recommendation to proceed with surgery? And this is a scenario we're certainly all seeing more in our clinics. So from a surgical standpoint, how would you frame expectations when meaningful preoperative weight loss occurs with medication, Adrian?
It depends, in my opinion, on the patient's BMI and the severity of the metabolic dysfunction. I'm very explicit with patients that pharmacotherapy-induced weight loss does not replace the long-term durability of metabolic surgery or the effectiveness outside of a clinical trial. In the real world, that's never been shown. Even when patients lose 10 to 15% of their total body weight preoperatively, surgery still offers superior and sustained weight reduction, being able to keep that weight off long-term. Metabolic disease remission, diabetes remission, and even a superior survival benefit, particularly in those patients that have obesity and type 2 diabetes.
No, Adrian, I absolutely agree. I think that for our patient population, preoperative weight loss can be extremely beneficial from a technical standpoint, with reduced liver volumes, improved visualization, potentially shorter operative times. But I do feel very strongly that this should not become a moving target for surgical eligibility.
Yeah, and I think we need to be clear that response to these medications doesn't mean that obesity has resolved or it won't recur if the medications are stopped, and nor does it negate the indication for surgery. In fact, the ASMBS guidance supports surgery based on disease severity and risk, not on short-term response to therapy. So the question shouldn't be, should she still get surgery, but rather, how do we integrate these therapies to optimize our outcomes? So let's talk about operative planning, particularly with GLP-1 based therapies. What concerns are you all navigating, Adrian and Crystal?
So the most immediate issue is delayed gastric emptying. We see that when we do endoscopies. We see that with our anesthesia colleagues for general endotracheal anesthesia. We now recognize that GLP-1 receptor agonists, especially higher doses or dual-incretin agents, can significantly slow gastric emptying, even in patients who do not have symptoms. But we'll see patients who complain about increased GERD. And to some degree, I just don't feel that it's fair for us to point that out as a weakness, because that's to some degree how they work, but as a side effect. And it's important to keep that in mind.
Right. As you mentioned, Adrian, there are some anesthesia concerns here when you're talking about putting people under general. There's increasing awareness of the aspiration risk that goes along with these medications, especially in patients who appear NPO compliant, but may still have some residual gastric contents. In our practice at our institution, we closely coordinate with anesthesia. For those who are on weekly GLP-1 or dual agonists, we typically hold the medication for at least 1 week preoperatively. Patients that have a lot of symptoms such as nausea, vomiting, or known gastroparesis.
Yeah, and we're pretty similar here. But also, I think if a patient is reporting a lot of early satiety, bloating, or nausea that's very close to the operation, sometimes we might even consider delaying surgery. But obviously, that's a highly individualized decision because you have to balance the risk of proceeding with the risk of delaying surgery. And this is where our protocols, I think, are still evolving. Until we have more data, this should be an individualized risk assessment and communication with anesthesia.
It's definitely essential and also important to consider the pre-op optimization of nutrition. Some of these medications can compromise that. With the use of obesity management medications, we must ensure that our patients are maintaining nutritional adequacy while also losing weight. As you well know, patients entering surgery in a catabolic or protein deficient state may have impaired tissue quality, reduced physiologic reserve, and potentially a greater vulnerability to stress responses during surgery.
Yeah, and in addition, if they begin the initial post-op phase already protein depleted, they're certainly at higher risk for sarcopenia, poor wound healing, delayed recovery, or obviously, I think all of us would be concerned about an anastomotic or staple line leak. In these cases, what looks like early post-op PO intolerance might actually be an exacerbation of either pre-existing nutritional compromise or just continued GLP-1 medication effect.
Absolutely. And this is why the adequacy of nutrition has to be protected so that surgery doesn't tip the patient over into overt malnutrition. But let's pivot to what may be the most frustrating part of this scenario: insurance. I don't know how insurance is where you all are, but where we are in Florida, it can be a challenge. Insurance is where the system can become quite irrational. Many payers will approve bariatric surgery for this patient, but then deny coverage for obesity management medications, even when those medications are clearly improving the health of the patient preoperatively.
Crystal, insurance is synonymous with frustration, and it's not just access to care, but also utilization when patients have access to care. So in many cases, when the patient assumes the financial risk of the medication, they're okay with that. But when they have to pay for it, they're not. And they're not okay with surgery if they have to pay for that also. And in some cases, paradoxically, we see an opposite concern where payers are questioning surgical necessity because the patient is actually doing well on medication. And as we mentioned earlier, that is not a reason to delay something that can add durability to the weight loss. Despite meeting the criteria of having a chronic relapsing disease, these patients are excluded from having those benefits. That creates a perverse incentive. Surgery is covered as a one-time intervention, but the medical therapy that could optimize patients before and after surgery is often excluded. It's very difficult to make sense out of all that, despite the fact that we have so much evidence-based reasons to provide these therapies for our patients.
Yeah, and we're seeing this play out in California. As of January 1st, they are highly restricting the GLP-1 access for our Medi-Cal patients, which is our version of Medicaid. So that's going to be a real issue in the state. And this fragmentation really undermines a chronic disease model of obesity care. So now we're being forced to choose between therapies that should be complementary and oftentimes might be more effective in combination.
I think the main takeaway from this case is that the integration of OMMs should start preoperatively with very clear expectations, very clear and coordinated perioperative planning, and continue advocacy for our patients from the payers.
Today's episode of the Behind the Knife podcast is brought to you by our presenting sponsor, Gore Medical Products Division. When it comes to ventral hernia repair in high BMI and comorbid patients, strength matters. Gore Cinecore biomaterial is a permanent mesh that is built like a lightweight, with the strength of a heavyweight and has 0 reported mesh fractures. With a less than 1% recurrence rate in ventral hernia working group grade 1 and 2 patients and a low rate of infection, Cinecore is designed to support your complex ventral hernia repairs. Visit goremedical.com/btkpod to learn more and ask your Gore representative about sizing and availability. Gore Cinecore biomaterial, no compromise for your high BMI and comorbid patients. Intended for U.S. audiences only, Gore is a financial sponsor of this podcast, which has been independently developed by the presenters and does not constitute medical advice from Gore. Always consult the instructions for use prior to using any medical device.
Now let's discuss how medication is being integrated after bariatric surgery. I'll start with a case. A 19-year-old woman with severe obesity and insulin resistance undergoes a sleeve gastrectomy. She initially loses 22% of her total body weight over the first year, who then plateaus at 18 months, remaining at a BMI of 36. She's adherent to follow-up, denies maladaptive eating behaviors, and her sleeve anatomy looks intact on imaging. Given her age and long disease horizon, the team considers adding pharmacotherapy.
Yeah, and this also mirrors what we're doing routinely in our pediatric bariatric program, where these obesity management medications are often considered part of the long-term treatment plan rather than a rescue therapy.
Yeah, we need to normalize the idea that bariatric surgery is not a standalone cure. So to say, the idea of multimodal therapy that includes surgery, medicine, and behavioral health therapy. Obesity is a chronic, progressive, relapsing disease. I always love to say that. And obesity management medications are a legitimate adjunct in its treatment, particularly in cases of inadequate weight loss, early plateau, and weight regain. And it's important for bariatric surgeons to understand the definitions of inadequate weight loss and weight regain. And there's some great studies out there showing the efficacy of these medications in patients who have had weight regain. In those situations, you could actually lose about 2/3 of the weight again using obesity management medications. And in some cases, patients lost even more than they had lost at their lowest with bariatric surgery. So their legitimacy as an adjunct is tremendous.
Exactly. And we've accepted this model in pediatrics for a long time. And I think the adult practices are starting to come around similarly, where pharmacotherapy is often initiated early after surgery to maximize durability, not just as a rescue therapy. And in adults, we typically tended to wait until weight loss stops or until regain occurs. And at this point, it just might be too late for a rescue therapy.
In our practice, the indication is not failure, rather, but just persistence of disease. So if the patient is plateauing above a healthy weight, medications can help re-engage weight loss physiology. But, timing can be a challenge. So, Matt and Adrian, when do you guys consider starting medications postoperatively?
Yeah, in my practice, I generally avoid initiating OMMs in the immediate postoperative period. Very early on, there's weight loss that is driven by surgical restriction and hormonal changes that occur with surgery, and adding medication too soon risks intolerance and nutritional compromise. It's very important early on to ensure that the patient has plenty of nutritional intake to maintain vitamin levels, etc. But once you get to the 3-month point and you can see that the patient is possibly not doing as well and the weight loss may be inadequate, that's time to pull the trigger to augment the potential capabilities of surgery. Matt?
Yeah, and I think our traditional model had been to delay it, wait until the patient's clearly on a regular diet, they're having adequate nutritional intake, and then their weight loss curve starts to flatten, typically around the 6 to 12 month post-op period, and then consider starting. That being said, in select high-risk patients, we might initiate these earlier. And certainly in our pediatric practice, we are being very aggressive at initiating these as early as the 4 to 6 week postoperative visit. And we do have some prelim data that we're actually going to be presenting at ASMBS showing better weight loss and no increase in complications, because that was always our fear. If we start them early, we might cause vomiting and an anastomotic leak or staple line blowout. And I think the data now says that's probably not a valid concern.
Now let's talk pharmacokinetics and tolerance. As we know, after sleeve gastrectomy and especially Roux-en-Y gastric bypass, drug absorption can be altered, particularly for oral agents. Thus, injectable GLP-1s can be favorable. However, patient tolerance can be the limiting factor.
Yes, absolutely. So nausea and vomiting, of course, are major concerns, especially in patients that have small sleeves or tight pouches. What might be considered a very tolerable dose for them preoperatively can be very problematic postoperatively with this change in their anatomy. And so I think this is where lowering the starting doses, slower titration of doses, and symptom-driven escalation are essential. If patients can't maintain their hydration or their protein intake, then the medication absolutely needs to be paused.
And nutritionally, what should we be watching out for?
GLP-1 receptor agonists specifically, and those similar therapies, further suppress appetite in patients who already have a restricted nutritional intake postoperatively. This increases the risk of micronutrient deficiencies, sarcopenia, and loss of lean body mass. We're particularly vigilant about protein intake, iron, B12, fat-soluble vitamins, especially after hypoabsorptive procedures. And in patients who have additional problems with postoperative nausea and vomiting, you've got to be aware of the potential for vitamin B1 thiamine deficiency. It's a key nutritional deficiency to keep an eye on. So adding GLP-1s to someone who's already having a decreased intake from surgery is something you've got to be very cautious about. The key is that medication should never compromise nutritional adequacy in any way. If weight loss is accelerated at the expense of protein intake or with a loss of lean body mass, that's really not a success. That's not the way that we want to achieve weight loss.
Very good point. Now, there's also concern that medications may overshadow the critical postoperative period of habit formation. Patients still need to learn portion control, mindful eating, and physical activity. How do you all frame medication integration for your patients?
Yeah, so when I talk to people just before surgery in general, I frame it all like that. And it's no different when you're having this conversation about medications. Because it's a support, it's not a substitution. So surgery, medications change physiology, behavioral change is what sustains these changes. And so if we use OMMs without reinforcing the lifestyle adaptation that is required, we risk recreating the same sort of dependency cycle that leads to relapse when the therapy is withdrawn.
Yeah, so I think the postoperative message is clear. These medications are powerful adjuncts when used appropriately after bariatric surgery. But you have to be very careful using intentional timing, paying careful attention to their nutrition and intake, and continued emphasis on behavioral adaptation. But when integrated thoughtfully, these medications can certainly extend the durability of surgery and the overall health benefit to the patient rather than compete with it.
Now we've learned about preoperative and postoperative integration of obesity management medications with bariatric surgery. To close the episode, let's zoom out and discuss the systems levels challenges surgeons face. Because even when the clinical rationale is clear, implementation is often not. Let's start with insurance, which is often the biggest obstacle. One of the most frustrating inconsistencies is variable coverage for obesity management medications after surgery. Many payers will cover bariatric surgery as a one-time intervention, but explicitly exclude medication cotherapy once surgery has occurred.
And that creates a major problem when we're treating obesity as a chronic progressive disease. We're then expected to manage long-term outcomes, but the tools needed to do that and the best available tools are not consistently accessible to us.
This is like a really sore spot for me. I feel like this resonates in my soul so much. From an advocacy standpoint, documentation is critical. Framing weight loss, or rather weight regain or insufficient weight loss, as disease persistence, not a failure of the surgery, is essential when appealing these denials. In the appeals, like our bigger group with our metabolic center sort of esque practice with our obesity medicine colleagues, it's been really helpful to clearly document the indication, plateau or regain, along with their prior response to surgery, adherence to follow-up, and the medical necessity that is consistent with chronic disease management.
Insurance aside, integration requires coordination. How is this playing out in practice?
Yes, but so now there can be a disconnect between bariatric surgery programs and obesity medicine specialists. But as you just heard from Adrian, many bariatric surgeons are getting their boards and becoming obesity medicine specialists, which I think is the ideal. So patients might be prescribed these medications outside of your surgical practice, and sometimes without a good awareness of the altered anatomy or nutritional risk. And obviously, this lack of communication can lead to problems with dosing, poor tolerance, or nutritional compromise. So we really need clear handoffs and shared care models when these are being done by different providers.
Exactly, Matt. In our center, we're working on standardized protocols, when to refer, when to initiate OMMs, and how to monitor patients postoperatively. But adoption is variable across the various institutions and practices. And without standardization, patients receive mixed messages, and that undermines trust in the continuity of care.
And, it's really important to maintain that trust so that we can continue continuity of care. From the patient perspective, patients sometimes view surgery as an option only if medications fail, or conversely, they see surgery as a failure if medications are needed postoperatively.
That's why language matters. We need to clearly frame OMMs as complementary and not competitive to surgery. I tell patients that surgery can change anatomy and physiology. Medications and surgery can modify neurohormonal signaling, and behavioral therapy changes and sustains both. There's no single modality that treats obesity in isolation, and that's why I think the idea of metabolic centers and multimodal therapy have to be promoted.
Yeah, and this is particularly important in the current environment where these medications have hit the popular media. You can't surf the internet now without being assaulted with multiple advertisements to get your easy GLP-1 access. But there's certainly less discussion about integrating these medications with surgery, so patients might not even be aware of that option. Ultimately, we need evidence-based frameworks from standardized trials to guide patient care and help create informed, individualized options.
Okay, so what do you guys think are some newer medications coming down the pipeline?
Well, obviously, these are highly effective medications, and there's a lot of interest in developing new and better versions. At least as of May, there were over 40 new GLP-1s in development. There are several oral GLP-1s, one now which is FDA approved, and several others coming on the market. There's another medication that's a triple agonist for GIP, GLP-1, and glucagon, and shows about 24% total weight loss in phase 2 trials, so pretty impressive results. There's also a monoclonal antibody to GLP-1 and GIP called Maritide, and this is a once-a-month injection, so even more convenient versus the weekly or daily injections. And they've shown 20% total weight loss in phase 2. So a lot of medications in the pipeline and that will be coming on board, and I think we can just expect better and better efficacy with these medications.
I think, as these sort of medications continue to be developed and come out of the pipeline, I think cost will be a major discussion with these as well. There's pockets of the population that can have access to these, and then there's pockets that cannot, just from sheer lack of affordability.
Yeah, and I think it shifts the surgery discussion too, of now surgery is looking like a much, much more cost-effective option if you're just purely looking at cost compared to lifelong therapy with some of these expensive medications.
I think it's also important to put in context that these are clinical trials that do not necessarily reproduce the findings and the results that we're going to see in the real world. But it will also increase the number of people who will look for treatment of their obesity. And with a larger number of people seeking that treatment, there will be a larger number of people who will opt for a permanent, durable, and effective therapy such as a bariatric procedure.
Now to wrap things up, what's clear from this conversation is that obesity management medications and bariatric surgery are not competing therapies. They're complementary tools in the treatment of a chronic relapsing disease.
Yes, Katie, surgery remains the most effective, the most durable intervention. It continues to reign supreme. And in terms of the ability to bring obesity and metabolic dysfunction and conditions into remission, there's really nothing that has been shown to be as effective. But we have medications that can play an important role before and after surgery, and that remains a very important point, and they have to be used intentionally and with attention to nutrition and tolerance and the long-term changes in physiology and neurohormonal response. And they have to be used together with everything we have in our armamentarium to combat this difficult to treat disease.
And as surgeons, we're now being asked to think beyond the operation itself with coordinating care across disciplines, navigating insurance barriers, and helping patients understand that needing medication after surgery does not represent failure. Again, this is sort of where the language is important.
And I think that's the challenge moving forward in aligning our systems, our messaging, and our published evidence. So patients aren't forced into either or decision scenarios, but instead are offered integrated, individualized treatment pathways. And ultimately, that's the goal, right? Durable weight loss, most importantly, improved metabolic health, and care that reflects the complexity of obesity as a chronic disease. So with that, we'll wrap it up. I want to thank everyone for joining us. I want to thank my co-moderators, Katie, Adrian, and Crystal. And we'll say it all together. And as always,
Dominate the day.
dominate
The day.
The day. We're the worst.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.